Hi, it's Dr. Noel Williams, July 29th, 2020, Oklahoma City, Oklahoma, Optimal Health Associates. Sorry I haven't done one in a week. I was in Colorado for a few days, and then Kim's been gone, and I don't know how to do any of this, but I'm trying tonight. A few updates. Obviously, there's been some changes. There's some clear differences of opinion on stuff, which is pretty humorous. So let's talk about that stuff. First, big shout out first to Amy Rappaport for making Hugo's birthday cake for me and bringing it over on Sunday. Thank you, Amy. And then an even bigger thank you to the people at Digestive Disease Specialists today, Dr. Carl Ruskowski, Nurse Mary and Maggie, the staff, Nurse Anesthetist Cole, and then Misty Cheney, Dr. Ruskowski's ARNP, for their help taking care of me. So thanks, everybody. Great group. Can't say enough about how high quality they are and the whole group is. And we were really lucky in Oklahoma City. The generation of gastrointestinal doctors throughout the community are really pretty outstanding, whether it's DDSI or the people at Mercy, Randy Kakish, or Neil Roberts, or Sam Hong, or Dr. Bird, or Dr. Black and Norman. They're just great GI doctors everywhere. So that's one nice thing we have in Oklahoma City, besides great cardiologists and great critical care doctors. So very lucky. So what's the update today? Well, I think the first one is we had 14 deaths today in Oklahoma City, reported today or since yesterday. So we're over 500 and on pace to hit 600 in August, unfortunately. The hospitalization rates are peaking. We have over 600 people in hospital. The Integra system has almost 100 patients in hospital. I think they had 12 or 14 admissions over the last 24 hours. The Deaconess campus is open. I think they have 40 beds. There's somewhere around 30 to 32 beds that are full. So that is pretty significant. I think there's 20 some on ventilators. Mercy, OU, most of those places have 25 to 30. The VA is now on divert for inpatient elective surgeries because they have so many COVID patients, because they're getting patients from all over the state. So the people getting sick, unfortunately, are now hitting the hospital. The volume of cases has gone up so much, we're starting to get more hospitalized people, which is, again, what our focus needs to be on, is how do we stop that? And that's what I'm going to go back to and back to and back to, so people can get a hold of what I'm trying to communicate, because you have to kind of block out your preconceived notions. You have to block out politics. You have to start thinking about the actual problem we're having, which is COVID infection. It's not about anything else for me except that, and preventing people from dying and preventing people from getting really sick. And so we're going to go over some data about that. Nationally, over 60,000 cases. I think we have the biggest number of deaths we've had since April. We're well over 150,000 now. I think 150,001 or so. And those numbers are going to keep on escalating. I mean, we're currently on pace to average about not quite 2 million cases a month moving forward, and that's without it being winter, where it is going to, the COVID is more infectious in the winter because it's optimal. I mean, there's been debates on its optimal temperature for proliferation, but in one of the original studies, it was somewhere around 40 to 42 degrees. So as we start getting cooler, it's going to get even worse. Now, it's not a seasonal virus yet, but it still has optimal temperatures. So that's what we have to think about moving forward. So let's talk briefly about schools first before we go into other things. Schools are going to open in some places, and I've spent a lot of time on this with many other physicians, but more importantly, school administrators and teachers have spent unbelievable amounts of time on this. And depending on a school situation, it's either going to be easier or harder to open. If you look at one of the, either North Dakota or South Dakota, they're going to open without masks. They have a very low prevalence. And they feel very comfortable about doing that. Now, the teachers are not excited about that, which I am very, very supportive of, even though I wish we didn't have to have children wear masks. This is how you have to look at this. Okay, if you figure there's 40 million kids in the United States who are under 14, roughly. And a teeny tiny percentage of them are going to actually get infected. And let's just say 1%. 1% will get infected and be infectious. That's still 40,000 kids. And even though they're at a low rate of infection, and if everyone has masks on, it becomes really, really hard for them to become infectious. And there's some analogous data that's been published looking at COVID in a hospital setting. And when they looked at 250, and I'll put this journal article on, thank you, Dr. Ruskowski, for going over it with me today. When everybody had gear on and they knew there was COVID patients, there was a zero transmission rate in 257 hospital workers. When they didn't know if people had COVID and they weren't doing universal precautions, people weren't wearing masks, over the course of several months, there was approximately 430 healthcare providers exposed, 10 got infected. Again, illustrating the difference between, even though it's a small group, if you don't wear any protection, there's always the opportunity to get infected. So when you look then at kids who are minor secretors at worst, and very rarely even secrete at all, there's still a tiny amount that will. So if you have everybody wearing masks, I think it's way safer. And if you have a plastic sheeting between the teachers, and then you're focused on wiping everything down, those schools are going to be in really good shape. But we have to see. And that's one more thing that seems to get lost with people, which is, again, science is not politics. Science is not a baseball game, but maybe in some respects you could argue it is, because during a baseball game, things change. That's what happens with science. Like someone texted or responded to one of my last posts about, well, you think elderberry's good, you weren't very positive about it before. Well, I wasn't positive about it before, even though I thought it would work, because I didn't have scientific data to support its benefit well enough for me to recommend it. That changed. We had better data. Just like the current data on children is very reassuring. I read an article saying, well, those trials are small and so they don't count. Well, small trials count. And the reason the data is small is because they haven't gotten infected. That's the kind of the thing that gets me on this. They haven't gotten infected. They didn't get infected in the schools that reopened or stayed open. So we still have to go with that and then adjust it if it changes. But again, even in the infected kids, they don't get that sick. And if you think about schools for a second, since the vast majority that open are going to have masks on, separations with the teachers, all kinds of sanitizers in place, we're not just addressing COVID, which is the least important one for children under 14 and really almost 18. It's going to affect influenza rates massively. It's going to affect strep throat. I mean, how many of us have kids who almost every year get strep throat? It's going to affect Epstein-Barr virus or mononucleosis. It's going to affect RSV, respiratory syncytial virus. And even almost most importantly, it's going to affect walking pneumonia, which really can get people sick. And if you look at the kid data on who's been hospitalized when they had a positive COVID culture, 50% of them have a more important prominent infection, mono with walking pneumonia, respiratory syncytial virus with walking pneumonia, or just walking pneumonia, which is a dramatically negative thing for a kid to get. And so the plan for this year, which maybe may become the plan so we stop illness at schools, is I hope not, but it could, it's going to affect all those. So that's a positive for us. So let's talk about Dr. Stella. So getting to it a little late. So Dr. Stella, who is I think she's from Houston, I really didn't focus that much on her details. What I was focused on is what she was trying to do and what it accomplished. What she was trying to do was highlight hydroxyplaquenil as an outpatient therapy and her success with it. And the thing I liked about what she was doing was her energy was that, and I mean this nicely, it was a little crazy. She had crazy person energy. And but she communicated that in her experience, they have had phenomenal results with hydroxychloroquine. And it caught people's attention, and it made people start to think, and is making people start to think, we need to do something before people get so sick, because we are doing nothing and we have no direction from the FDA, CDC, NIH, Public Health Service, or any umbrella medical organization on how to treat people outpatient. And when people get mad that someone is questioning the narrative, let's stop that and think, the whole goal of all those organizations was to prevent this from occurring, which they completely failed at. They were supposed to then limit spread, which they completely failed at. And that was them, that wasn't Trump, okay? Trump has a whole laundry list of mistakes, but this isn't a Trump issue. This is an NIH, Dr. Fauci, Dr. Redfield, I would say Secretary Azar, and then most importantly, Robert Kadlec, who was the Assistant Secretary of Preparation at the FDA. They all knew in November and December it was coming, knew it was here in January, and did nothing. And that's why we ended up snowballing. And then if you're someone who hates Trump, that's when Trump then made his mistakes. And those of you who are pro-Trump, you can email me and tell me what a rat I am for saying it. But hey, it wasn't a hoax, period. It was never a hoax. He got all wrapped up in other stuff. But the bottom line is then he made some mistakes. And so you then snowball it up. But the initial ones were all pre-executive branch. And that's where I get so frustrated. And they continue to be pre-executive branch because they won't address outpatient therapy. And why is outpatient therapy more and more important? And I'll post this study tonight. There's a great study from JAMA and the subjournal on cardiology that shows that 78% of people who get symptomatic COVID, even mild infections, have heart damage months and months later that's ongoing. COVID is a nasty virus. And that's another important point. Now, the person who wrote it was, again, criticizing Trump, which to me missed the whole point, and that's what people don't get. Talk about the virus. He says, well, Trump has said it's a nothing. That's a mistake, but highlight the fact that no, this virus is deadly for months and months after you've recovered. And we need to do something. We need to get people troponin levels serially after they recover. They need to potentially, and if those are elevated, they need to get at least echocardiograms. What can we do to turn off inflammation in the heart and limit post-COVID heart attack? That's where we need to focus and stop recriminations and start functioning to prevent death and not dismemberment, but just everything. So then let's get back to pre-treatment. So or treatment before hospitalization, which the only recommendation is wait for somebody to get sick. If we can stop people from getting sick immediately, whether it's Plaquenil or it's something else, let's figure it out. Let's figure it out. There's data showing doxycycline can be an antiviral. There's data showing that mebendazole, which is the dog dewormer, which some of us will use for cancer patients, can have antiviral properties and can take out RNA viruses. There's data on Zithromax that can do that too. Do a double-blinded randomized controlled trial. Let's do something, FDA, to try to see if we can prophylact against it if you're exposed, or an early treatment strategy. And why not follow some of the recommendations from other authors who have taken care of these patients and come up with this plan I've mentioned many times now, that you get them on an antibiotic pretty quickly. You get them on elderberry. You have them nutritionally repleted. You think about a mild steroid. In that study, and I want to, again, the Plaquenil thing is so divisive, which drives me insane, and they would start them right away on Plaquenil because Plaquenil is harmless. Look, I'm getting really close. Read my lips. Plaquenil is almost harmless. Okay, now there can be side effects, but in terms of medical effects, the data is completely clear. And that gets back to the FDA too. So here you have the central reason they said they couldn't use it and don't want to use it is because this bad heart study, even though their own data says that it's fine, and historical data, but it's horrible in the JAMA study. And then not the JAMA study, the Lancet study out of England, which gets repudiated and retracted. And the doctors have formally apologized for it all. And they still won't address it. Now, the EU's opened up all these Plaquenil trials again. So the EU can adjust, but we can't. And so it gets crazy. And so the central part is, let's figure out a treatment strategy before they get to the hospital so they don't need to go to the hospital. I don't want to go to the hospital with COVID because I know once I get admitted, ultimately I have about a 50% chance of dying. So the goal is not to get admitted to the hospital. And if you're admitted to the hospital, you have at least another 50%, if the 50%, so let's say 20% get admitted, 10% roughly are at high risk for dying, another 5% are at high risk for long-term morbidity. And then you look at the group that is outpatient still, 70% of them plus could end up with long-term heart damage, and another 10% or more will have other damages in their kidneys or liver or brain, or lungs at least. So we want to stop the disease, and that's the theme. I don't know why everyone's so mad about that and gets mad at me about saying that. I want you to think about it. Do you want to have damage from COVID? And just hope you get better before that, which it looks like your relative chance of not having any damage is probably only 10 to 20% at the most right now. I mean, that's crappy. So people getting mad about me wanting to not have that happen to not just my patients, which I will never stand for my patients having that. I mean, everyone who I take care of knows how I am. We do not tolerate our patients being at risk. We will do anything for them that's reasonable. But that's what everyone needs to be getting, that same level of care. So we have to think about it. So again, core stuff. Again, zinc daily. If you've been on zinc daily for a couple months, skip the weekends. Your alpha interferon's in great shape. Multivitamin. Get those initial macrophages, a type of white blood cell, revved up to fight that virus at the intake. Vitamin D. Complete supplementation on the same stuff, and then other parts of your immune system. Melatonin. I was rereading that data today. The melatonin interference in the inflammatory cascade is fairly impressive. Take the melatonin every day. And then if you do get COVID, let's talk about a slight difference. If you do get COVID, what do you want to do? You want to pump your melatonin way up. I mean, I would go either minimally to 10 milligrams twice a day. Number two, vitamin C at that point. You want to pump your vitamin C up. I think on a daily basis, the vitamin C in a multi will cover you just to have your immune system tuned up. But if you get COVID or any influenza, pump your vitamin C up to 2 to 3 grams twice a day. Third, elderberry. You add the elderberry immediately at any viral infection. Again, to start knocking it down. And then the thing I'm beginning to wonder about, which again, I'm just brainstorming at this point a little bit. I think you want to really start thinking about fish oil because of all this heart inflammation. Heart inflammation is bad. I take fish oil every day. If you don't take fish oil every day, I would encourage you to take at least one a day anyway. But with COVID, you definitely are going to want to take 2 a day if you start getting any of those symptoms or if you turn out to be positive. And then turmeric, because turmeric is, again, hard on the stomach. So just a small dose, 250 milligrams if it's a normal turmeric. If it happens to be Meriva, which is a Thorne product you can get online, one of those a day absorbs totally different, so it's 250 milligrams, but it's really like doing an IV dose every day. And if you get COVID, you do it twice a day. And then you always pulse the zinc at the first signs of a flu or a COVID infection. And we've had a lot of people do that now who've ended up being COVID positive, and they've had very minimal infectious events. And again, I need more people. I mean, we've had 20 some COVID positive patients so far, so we need to hit 100 and see what the trend is across that group. So far, our group has done great with zinc alone or with adding the Plaquenil to the zinc. So, but my people, almost all of them, are already on vitamins. I mean, that's what I'm trying to do every day is prevention, which gets back to being in the public health service, which they forgot their job. So that's a very long talk. I haven't given one in a few days, so sorry. Be optimistic. Know we can get through this, and be calm, be kind, be nice. And don't get worked up when someone presents a new idea in terms of getting all mad. Think, maybe I got to question myself. I'm going to change on some of these subjects over time when data alters. I mean, if the data on Plaquenil, if there's ever a well-done trial, which is not the New England Journal of Medicine trial they just talked about, so showing it didn't work, it was for hospitalized ill patients, which is the least effective place to use it. Let's use it on an outpatient basis. Let's use it prophylactically. And remember, the hospitalized data is in huge conflict. It's in huge conflict. So that's why I don't know in the end if it's right or wrong, but I think the overall data shows it's massively still beneficial. But I think my focus is, let's think about it outpatient to stop the virus before it gets you sick. So, but let's do a study. We'll answer the question. That's all. Good night.